Good morning. As Maria said, I live in La Jolla, California now, and I'm not used to seeing this white stuff come down, and it's just sort of it was a shock. I know, thank you, and I appreciate it. Kathy asked me to talk about sort of a difficult problem in ophthalmology, and this is such a difficult problem that as neuro-ophthalmologists, we for years have had difficulty even naming this. We used to call it functional problems in ophthalmology, factitious problems. Some people are called malingerers, and I would advise you never to call anybody a malingerer because that implies that they're faking. You don't ever want to have a motive. And I think now there was a recent article that sort of convinced me at least that I'm going to call this non-physiologic problems with vision. Now let me ask a question or two. How many people here are the primary contact for patients that come into your office doing the visions, histories, et cetera, et cetera? Okay, most of you. How many of you, during that initial contact, dilate the pupils so that the first time the ophthalmologist sees the patient is dilated and behind a slit lamp? All right, so that's important because many of the things that you need to figure out if the patient's complaints are real fall upon you. Because by the time the patient's dilated, a lot of the information you need to know whether the patient has a non-physiologic problem is gone. So, if you don't do your job, you wind up with the ophthalmologist being like this, with his head up his can of Coca-Cola. Okay? And then going forward for the ophthalmologist to sort of, what am I going to do next? He winds up driving blind. Right? He's on autopilot, but all he sees is the crotch of this koala. All right? Now, I happen to like koalas, but if you're going 70 miles an hour down the freeway, you want to have more information. All right? So, it's easy for you to determine whether a patient is telling the truth or not if they come in with no vision in one eye, right? I mean, that's easy. Patient comes in, 20/20 vision in one eye, no light perception in the other eye. It's so easy it takes one test to determine whether a patient's faking or not. And that's the swinging light test, looking for an afferent pupillary defect. So, if you don't do an examination of the pupils that includes a swinging light test, you are not really doing a complete examination. In fact, on all the patients that I see, and I've done this for years, and I still do it, and I have residents and fellows working up the patients for me and the like, there are two things that I check myself on every patient, and one of them is pupils. I don't trust anybody to look at the pupils. I do, okay? And there are other things that you can do if a patient has no vision. You know, you have them patch the eye, that's good, and there's no light perception eye. But if patient says they have no light perception, and you shine a light in their eye and their pupil reacts, you know they can't possibly be no light perception. All right? If a patient is truly no light perception in one eye from any cause, their pupil will not react to direct light. And if it does, they're fibbing to you, okay? There are other ways to do this. We used to do optokinetic drum, but nobody has those anymore. Eye movements to a tilting mirror. I love this test. All right, I used to sort of grab the mirror off the wall, you know, the Snellen mirror, and hold it in front of the patient and say, look at your eye. And they say, I can't see my eye. I said, well, that's all right. Look straight ahead, but try to keep your eyes still. And I would tilt the mirror back and forth. And the more they tried to hold their eyes still, the more their eye would go like this. And then I would tip it this way, and their eye would go up and down, all right? So grab any mirror, your contact lens mirror, as long as it sort of takes in the entire view of the patient, and you do this, and if the eye does this, then you know that the patient has vision in the eye. You can always do threat, you know, you're sitting there and all of a sudden you go like that. I had a partner once who used to have a tennis ball on the edge of a string, and he would sort of rumble around in the drawer, and then he would sort of throw the tennis ball at the patient, and just sort of before it reached the patient, the string would stop, and just sort of one day he misjudged the sort of thing, and it went boom, okay? And I won't talk about the 4-prism diode base down test because that's a little bit too complicated. Now, my friend Simmons Lascelles in Boston has a group of cards that he uses, and I'm not sure I'm going to get into that with you. But testing the pupils, looking for an afferent pupillary defect, is really the thing that you should do. The other thing I would tell you is don't do it before you test the visual acuity. I always tell my residents, never ever shine a light in a patient's eyes, touch the patient's eyes, put drops in the patient's eyes until you document the visual acuity. You know, you shine the light in the eye to sort of test the pupils, and they go, oh my God, what did you do to me? I could see before you did that. Now I can't see anything out of the eye, and you don't have it documented. And you'll wind up in court. And they'll always find some doctor who will testify that, oh yeah, she did that, and that's caused the visual loss. There's no question about it. No question about it. All right? Now, the thing about the afferent defect is easy. You shine a light in the eye, the light impulses go back to the brain, and then they go back to the eye, and so that the eyes work the same. Okay? So they're always the same size. If they're this big, if this pupil is this big, because there's no light perception, when you shine a light in the no light perception eye, the other pupil will be that big as well. If you shine the light in the other eye, which is 20/20, both pupils will be this big. So that you're not looking at anisocoria, you're looking at pupillary reactivity. And this is essentially what you're looking at, okay? If you look at a patient in sort of dim illumination, this is what they look like. Their pupils are a certain size, any size. You shine the light in the affected eye, 2200, and both pupils constrict to a certain size. But if you then take that light and swing it to the other side, which is a 20/20 eye, both pupils get smaller. And if you then take that light and quickly swing it back to the bad eye, both pupils get larger. You swing it back to the good eye, both pupils get smaller. This is the swinging light test, and this is the relative afferent pupillary defect, all right? So that this is probably the most important test in all of ophthalmology, as far as I'm concerned, because, I mean, think about what we do. Patient comes in, you say, what's your problem? Okay? Read the eye chart down at the end of the room. Look at these color plates and tell me what you see. Press the buzzer every time you see the light in his bowl. Every bit of information that we make our decisions on is subjective. The patient's telling us. We have no way of testing whether they are objectively correct. This is one test that the patient cannot affect. Cannot affect. Patient comes in, no light perception. They have a normal swinging light test. You say, get out of here, you're faking. Now, how do you do it? This is how you do it. Shine a light in that eye, check each eye individually. This guy has a bit of an exo, but it's okay. That pupil doesn't react quite as well. You say, oh, so, but now watch. That pupil comes down, that pupil comes up. That pupil comes down, that pupil comes up. That pupil comes down, that pupil comes up, and it means this eye has a legitimate decreased vision. It's not no light perception because the pupil reacts, but it's a legitimate afferent pupillary defect. And this is the way you do it. You have the patient look straight ahead in a dimly lit room. You take the brightest light you have. In this case, I use the halogen muscle light. You shine it directly on, and you quickly swing it back and forth, all right? You don't sort of go like this, because what happens is the pupil dilates as you take the light away. So you go 1, 2, 1, 2. You hold it the same amount on each eye, and you swing it back and forth very quickly. And if you do that, and the pupils are normal, they should not change size at all. They should not move. If one goes up and the other one comes down, that's an afferent pupillary defect, okay? So that's important. Why is it important? Because there are certain things that produce afferent pupillary defects, and there are certain things that do not. An afferent pupillary defect just means that there's a certain degree of light, a certain number of log units of light that are not getting to the retina or the optic nerve or getting back to the brain, all right? And anything that produces that decrease in the log units of light will produce an afferent pupillary defect. So, contrary to what you might have heard in the past, a presence of an afferent pupillary defect does not mean necessarily it's an optic nerve problem. If someone gets hit in the eye and they have an 8-ball hyphema, they'll have an afferent pupillary defect. If someone has a total vitreous hemorrhage, they'll have an afferent pupillary defect. Likewise, a vitreous total retinal detachment, they'll have an afferent pupillary defect. So what I always tell the residents is, if you can see the retina and the retina looks relatively normal, the presence of an afferent pupillary defect means the problem with the vision is either optic nerve, optic chiasm, or optic tract. Now, that's pretty good for a flashlight. You know, I mean, you now have localized the neurologic lesion that this patient has to a very small area just by using the flashlight. Now, if the patient comes in and they have decreased vision and they have a cataract, and you didn't do this test or you didn't do it correctly, and the ophthalmologist doesn't see the patient until the patient's dilated, the ophthalmologist will assume that the decreased vision is due to the cataract. And after the cataract surgery, the patient will have no improvement in the vision. All right? I think it's bad form to then go back and do the swinging flashlight and say, oh, yeah, all right, you got an optic nerve problem. That's why you didn't get any better. Isn't it much better for the ophthalmologist to say, well, you know, you've got this abnormal pupil, and even though your cataract may be contributing to this, if and when we do surgery, your vision may not be perfect. You've already told the patient ahead of time, it makes you look great, because what you told them is really true. So this is one of the things I think you need to do on everybody, and then like most things in life, technique is critical. So get the technique down. Bright light, dim light in the room, patient fixating straight ahead. You know, you get the medical students in and they sort of stand in front of the patient and they go like this. Well, you don't ever do that, because what happens when you stand in front of a patient? They look at you. And what happens when they look at you? Their pupils get small. You can't tell anything about the pupils when they're this small, so you have to have them fixate in the distance and come in straight on with the light, bright light, 1, 2, 1, 2, 1, 2, 1, 2. And swing it back and forth quickly. So that's one thing I would urge you to do. And then work out in your own office. If you think there's an afferent pupillary defect, don't go ahead and dilate the pupil. Maybe have the ophthalmologist check it. Or the ophthalmologist would probably then say, well, we should probably do a visual field on the patient or some other test. Now, when don't you get an afferent pupillary defect? Cataracts, no matter how dense, never produce an afferent pupillary defect. So if a patient has a hand motion cataract, now I know that that particular disease has been cured in Philadelphia. All right? There are no more hand motion cataracts unless someone comes down from the Poconos, maybe, the backwoods of the Poconos, and stumbles into an ophthalmologist's office, all right? But cataracts never produce an afferent defect. So if a patient has a cataract and has an afferent defect, they have something else going on. Papilledema doesn't produce it. A refractive error doesn't produce it. So if a patient is minus 15 on one side and plano on the other side, it doesn't produce an afferent pupillary defect. It means there's something else going on. And brain lesions don't produce it. And here you notice I put down here, and this is what we're talking about today, functional or non-physiologic visual loss does not produce an afferent pupillary defect. Okay? So this is important. Now, I said to you that if you shine a light in one eye and the patient claims no light perception in 20/20 and they don't have an afferent defect, you say, get out of here, you're faking. All right? Now, what if the patient comes in and says, I have no light perception in either eye? And you shine a light in their eye and both pupils react normally and there's no afferent defect. Can that patient be faking? Sure, that patient can be faking. But that patient can have real disease because you don't get abnormal pupils with lesions posterior to the lateral geniculate body, which is right behind the chiasm, because that's where the pupillar motor fibers come off. So if you have bilateral occipital strokes and the patient has no light perception because of bilateral occipital strokes, the pupils will work absolutely normally. So one eye NLP, normal vision, the other eye, no afferent defect, out of here. Bilateral NLP, normal pupils, MRI scan to look for bilateral occipital strokes. Now, double vision. I'm sure you see a lot of people come in and complain about double vision, all right? And what do you think is the most important part of the neuro-ophthalmologic examination? Anybody? Well, you know the answer to it, so I'm going to say it, right? Did anybody hear Reggie? History. History is the most important part of the neuro-ophthalmologic examination. If I had a good observer on the other end of the telephone, I could do neuro-ophthalmology from my apartment in La Jolla looking at the Pacific Ocean. All right? It's that easy. It's that easy. What I would also tell you from the standpoint of the history is don't ever accept blurred vision as a chief complaint. What's the matter? My vision's blurry. Well, that could mean a variety of things to a variety of people. So what I always tell my residents is that I want you to understand completely what the patient is experiencing. What does blurry vision mean to you? Tell me what you can't do now that you could do before the blurry vision started. I had a patient last week who came in and said her vision was blurry. And she had 4 pair of glasses, and they did everything, this, that, and the other thing. And I talked to her a little bit, and I said, does your vision clear up when you cover one eye? Yes. And does it clear up when you cover the other eye? Yes. So you only have your blurred vision when you have both your eyes open? I said, yes. And the resident who had worked up the patient, I said, this patient has double vision. And he said, no, she's not complaining of double vision. I said, this patient has double vision. And sometimes the double vision is so close that it produces a ghost image that the patients interpret as blurred when it actually is double. Okay? So, what I'm going to sort of tell you here now is if someone complains about double vision, what are the appropriate questions to ask in that patient? All right? This is the most important question. Does the double vision go away when you cover one eye? And the patient says, what? This is such an important answer that if the patient has not done this, you then do it. What I do is I put the Snellen thing up there, I put the big E up, and I say, you see one or two? And I say, I see two. I say, all right, cover this. How many now? I say, I see one. How many now? I see two. That patient has monocular diplopia. Say, how many do you see now? I see one. How many do you see now? I see one. How many do you see now? I see two. That patient has binocular diplopia. They are two different things that are caused by two different things. One's a potential neurologic problem. The other is never a neurologic problem. So monocular diplopia in one eye is not a neurologic problem. It's an eye problem. And I'm not sure if I put in here what, here's what it's due to. I used to have cataract at the top of the list. And I was giving a lecture once, and an ophthalmologist came up to me and said, oh, nice lecture, I like your lecture. He said, but that slide is wrong. I said, what do you mean it's wrong? And he said, the most frequent cause of monocular diplopia is astigmatism. And I said, well, I'm a neuro-ophthalmologist. I don't refract people, so I don't really care, what I say. But in fact, he was right. Uncorrected or undercorrected astigmatism is the most frequent cause of monocular diplopia. And monocular diplopia is not one here and one here. It's this. It's a ghost image. In fact, if someone says, I have monocular diplopia, one's here and one's there, they're faking, right? There is no monocular diplopia except for a dislocated lens that will give you one object here and one object here. So just by the history of where is it, you know whether the patient's faking or not, all right? So that monocular diplopia is produced, as you know, the pencils of light come in parallel, and then they get bent by the cornea, they get bent by the lens, and they come to a point focus on the retina. Anything that interferes with the lights coming in produces not a point focus on the retina, but a blur circle. And that produces monocular diplopia, all right? And since the cornea is the most highly refractive surface, not the lens, but the cornea, any abnormality in the cornea, especially astigmatism, can produce this blur circle and monocular diplopia. And some of the other things will do it as well. And cataract does it. I'm always amazed. I'll see 3 or 4 patients a year sent in by general ophthalmologists that have decreased vision and a little bit of double vision, and they have nuclear sclerotic cataracts that don't look that bad, but they in fact are causing the problem. Okay? So what you need to do, if someone comes in and has monocular diplopia, is you probably have to refract them. But since I don't refract, what I do is I put a pinhole up. If the monocular diplopia is due to a refractive error or a cataract, once you put the pinhole up, it goes away. So then you know that that patient needs a refraction or they need cataract surgery or something else. If it doesn't go away, they're probably faking. All right? So the pinhole is a real good instrument. How many of you use a pinhole? Yeah, because you use it to sort of say, oh, it's 2080, about 2030 pinhole, right? So this is another use for the pinhole. So if the patient says, no, I see double vision only with both my eyes open, then what I ask them is, I'm trying to figure out why. Now, the only thing that can produce double vision with both your eyes open is ocular misalignment. So if you see someone who has binocular double vision, their eyes have to be, okay, never straight, all right? So the way I look at it is the double vision that you see, is it side by side or one on top of the other? Say side by side. Well, now I know that the double vision is being caused by one of the horizontal muscles, either the lateral recti or the medial recti. So how do I tell? Say, well, is it worse when you look to the left or to the right? Say, it's worse when I look to the right. Well, now I know it's either the right lateral rectus or the left medial rectus. Okay? Is it worse in the distance or when you read? Oh, no, I can read fine. It's only when I look in the distance. Well, now I know the medial rectus is normal because the patient can get their eye in when they want to read. So I know what the diagnosis is before I examine the patient. They have a right abduction deficit. Okay? So that's how easy it is. But the important thing for you is the top one, distinguishing monocular from binocular double vision, because monocular double vision can be a non-physiologic complaint. So can binocular double vision, but patients are usually not that smart. You know, say, how many do you see here? 2. I say, how many do you see here? 2. How many do you see here? 4. And then I'm going to show you how to do confrontation fields, and that's even better because I say, how many do you see here? They say, 4. Well, how many do you see here? And then you see them going like this. So you know that they're... This lady has double vision.
This is a young lady who's had an eye movement problem for several months now. She complains of intermittent double vision that happens probably every day and a couple of times a day. Is that right?
Yes.
Yes. And as you can see here, as she's looking straight ahead, her eyes are straight. She does not have an ESO or an exo deviation. We measured this in the clinic. Now, I want you to look right here towards me, just with your eyes. Look right over here towards me. Way over here towards me, way over here. And as you can see, she develops an abduction deficit of her right eye. Now look straight at the red light of the camera. And as you can see, it's really marked here. Look straight ahead at the camera. You're doing great. You're doing great. Now, that's better. Close your eyes. Close your eyes.
So this lady was worked up for myasthenia and all sorts of by neurologists.
All the way to the left. Way out there to the left. Way out there. Keep looking out there to the left. Way out there to the left. Way out there. That's great.
It doesn't happen so much when she looks to the left.
Okay, now look straight at the camera. All right. Now look way over here to me. And you notice...
So you say, my God, this woman must have some terrible
abduction deficit again occurs.
So what do you look at next?
This little thing here. Now watch this. Look way over here. Way over here. Way over here. And she has a little bit of it on the left eye. Way over here. Now look straight ahead. Straight ahead. Now let me see if I can show you her pupils.
Watch her pupils.
Yeah, we're looking at her pupils.
Look at the
now.
size of her pupils.
Look,
straight
size.
Now, right? Her eyes are straight.
Well, now look all the way over here to me. Look all the way over here to me. Way over here to me. Way over here. Now look straight back, straight ahead.
Now her eyes are crossed. Look at her pupil size.
They are now.
Much smaller. Much smaller.
Now close your eyes. Now open them, look straight ahead. And
now her eyes are straight and her pupils are back up to normal size.
All the way to me. All the way to me.
What neurologic problem is that?
And her pupil is much smaller here, even if you can't see it. But look straight at the light.
None. She's faking.
Straight at it. And as you
She's faking.
with her ET.
This is a typical spasm of the near reflex faker. All right?
Close your eyes.
And this woman had all sorts of a neurologic workup, CT, MR, EMG for myasthenia. And the way you tell is that you look at her pupil when she develops
Here we are
a crossed
focused
eye.
in on the right eye.
Here she is straight ahead.
And she's looking straight ahead. Things are looking fine. Now look here to me. Look here to me. Way over
And
here.
look at her pupil go down.
And you can see, obviously,
Why?
the
What is it? You know what the
meiosis that
near
occurs.
triad
Look
is?
straight ahead. and it's still miotic here.
Convergence,
still miotic.
accommodation,
And as her
meiosis.
ET goes away, close your eyes.
You cannot cross
and
your
open
eyes
fine.
without making your pupils
Pupil
smaller.
comes back to normal.
So this is a woman who, when I'm telling her to do like this, follow my finger, she's doing this. She's crossing her eyes voluntarily, and because her eyes are crossed, this eye is pointing that way, and it looks like she has a sixth nerve palsy, and she doesn't, okay? And this is sort of a more static way to look at it. Here's the patient in primary position. You see her pupils. Here she is when she's looking to the left, and it's normal. And look at her pupils when she develops this abduction deficit. All right? Now, how do I know she was faking? She was a photographer at Wills Eye Hospital and could do this. So I took her pictures. All right? So if someone develops, has what looks like an abduction deficit, and it's intermittent, and it's sort of fluctuating and stuff, look at the pupils. So this is another reason why I think that ophthalmologists are doing themselves a disservice by seeing the patient dilated for the first time. Now, remember I told you that there are two things that I do on every patient that I see. One is pupils, myself, and the other is confrontation visual fields. All right? Now, I don't particularly think that everybody needs visual fields who comes in your office, formal visual fields. I mean, that's crazy. I only do visual fields if I suspect that the visual field is going to contribute to my diagnosis. However, I think it's sort of bad form for a patient to come in, have a complete eye exam, and leave, and have a visual field defect due to a brain tumor that you didn't know about, okay? Now, how do you do confrontation visual fields? This is the way neurologists do visual fields. You, like every other visual field, you do one eye at a time. So you tell the patient, cover your left eye. You say, fine. And you always have to control their fixation, right? Look at my nose. Now, neurologists say, tell me when you see my fingers wiggling, right? Now, I think that's a terrible way to do visual fields for a variety of reasons. You know, I see patients who are referred in to me because the doctor says, well, you know, there's nothing wrong with your eyes. You may have a brain tumor, or you may have multiple sclerosis. We're going to send you to see the neuro-ophthalmologist. So I'm sitting there, the patient's sitting there, thinking they may have a brain tumor, and I'm telling them, tell me when you see my fingers wiggling. And they go, oh, my God, he's got wiggling fingers out there. I don't see them. If I don't see them, I probably have a brain tumor. Yes, yeah, I see them. I see them. Now, what kind of test is that? All right? When you're checking visual acuity, would you put up the Snellen chart, say to the patient, do you see the 20/20 line? They say yes, and you write 20/20. You wouldn't do that, right? You would say, prove to me you can see that line. Read that line to me. So I want my patient to prove to me that their visual field is intact. So I use count fingers. So cover your left eye. Look here. How many fingers here? 1. And I actually do. How many altogether? 4. How many now? 3. Cover your other eye. 2, 4. That's it. That's how long it takes to do confrontation visual fields. You can fit that into your busy schedule, all right? And notice, the patient had to count how many fingers I had, all right? And also notice that I didn't do it way out here, because you don't need to do it way out here. I mean, think about when all the visual fields you've ever done, they're 30-2s or 24-2s. So what's going on out here is going on in here. So make sure that you make it easy for the patients and hold it in to 24, 30 degrees, okay? So that's really important. So that's confrontation visual fields. There are other more subtleties on visual fields like color comparison, but at least you can do that. And then what I put down is FTFC, full to finger counting, by OU. And at least I know the patient has full confrontation visual fields. Now, the other thing sometimes you will see is a patient will come in, and on confrontation visual fields, they don't see anything out here. So you say, gee, they may have a constricted visual field. All right? Then what I do is I'll say to them, and I'll sit well, I don't know, a couple of regular in front of them, and I'll say, look up here, tell me when you see my finger. And they'll go, now. Say, okay, tell me when you see my finger. Now. And what I do if I suspect someone's faking, I use my face as a clue to them to when to say now. You know, say, when do you see it? When do you see it? Now. When do you see it? When do you see it? Now. Now, constricted visual fields can be real, right? Glaucoma, retinitis pigmentosa, all of those things can produce constricted visual fields. So how am I going to tell if that constricted visual field is real or not? Okay, I had a kid that came in to see me last week, 12 years old, 13 years old. Father said, oh, he's having trouble with his vision. And I said, well, how long? He said, oh, gee, we've seen the optometrist 10 times, and he hasn't sort of figured out what it is. And I said, but now he can't get him to 20/20, so he sent him to you. And I said, well, what's his problem? His problem is he's bumping into things off to the side, and he has problems seeing in the dark. I said, oh, kid's got retinitis pigmentosa. I mean, what else gives you those symptoms, right? So I do the visual fields. He's got constricted visual fields. But how do I know the kid's not faking? All right? What I do is I do the visual confrontation fields at two different distances. All right? If a visual field is this big here, what happens to the visual fields when I move back here? Do they get smaller or larger? If you're standing in front of the Liberty Bell this close, how much of the Liberty Bell can you see? And if you're this far back, how much can you see? So when you further back you go, it's counterintuitive almost, the wider your visual field gets. People who are faking don't understand that, all right? So I go, tell me when you see my finger now. Tell me when you see my finger now. All right, I'm going to make it tougher for you now, I tell them, all right? And when you double the distance, you have to double the size of the object, so I hold up 3 fingers. Tell me when you see my finger. Now. Now. They're faking. What my kid did was, now, 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 now. He was telling the truth, okay? And that's one of the ways to do, to look at confrontation visual fields, to get people who have peripheral constriction. Now, there's another test that I like to do.
This young lady who was in an automobile accident and is now complaining of decreased vision in her right eye.
And this works for NLP.
She actually tests at no light perception. Her vision in her left eye is normal. So we want to see if she has any function in her right eye. Do me a favor, cover your left eye with the palm of your hand and look right here towards my voice. Tell me, can you see my fingers here?
No.
Now can you see them?
No.
How about now?
No.
Now?
No.
Now?
No. 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 No.
What happened? Either no means yes, but I stopped saying no, and every time I held up my fingers, I stopped saying now, and every time I held up my fingers, she said no, 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 I don't see him there either, all right? So you can use this test for no light perception vision as well as for peripheral constriction. And I will tell you that this test works every time. You won't see this written anyplace. I've never written this up, and I've never seen it described. This is something that I sort of came up with. Now, this was one of our technicians, one of our front desk people from years and years ago. But trust me, it works. Trust me, it works. Okay, this is a woman that says that things are jiggling. Nystagmus. Okay? You know, things are jiggling. Her vision's bad. You know? So how do you, what is this? I wanted to start it again, but here you go. Have you ever seen that sort of nystagmus? She's doing it on purpose. That's voluntary nystagmus. All right, there are some people who can do that as a party trick, but I have seen people coming in and saying, "Oh, you know, I was in this automobile accident, and now I have this, that, and the other thing." And the thing that is important about this voluntary nystagmus is it looks like this. But in addition, people cannot sustain this for more than a few seconds. So what they'll do is their eyes will be going like this, and they'll go, oh my God, I'm so dizzy, to give themselves a rest. And then when they take their hands down, they do it again. All right? So that's voluntary nystagmus. And a lot of this goes away once you dilate the pupils and cycloplege them. All right? So that because the way they start this nystagmus is they converge. And I think I could show you that. This was a lady, I was doing pictures or something else. She said, oh, I can do this too. And you'll notice when she starts it, her eyes open wide and she sort of converges, and then sort of she goes like this, all right? That's voluntary nystagmus, okay? Now, she did this, I mean, she said, I can do that. I said, good, I don't have a movie of that, so let me do this, all right? However, some people have said that I'm a bit of a cynic, and I would say that's probably an understatement. The time that you have to suspect that you may be dealing with someone that has a tendency to fabricate some of their answers is when they're secondary gain, all right? Most of the people who come in are not crazy. Most of them come in for secondary gain, you know. If you know that there's a lawsuit going on, or if it's a workman's compensation thing, something that they're there to get some secondary gain, be extra skeptical, be extra cautious, make sure you do everything and make sure you document everything. You know, there was this famous case here in Philadelphia of one of the SEPTA buses got into an accident, and there were like 8 people on the bus, and 23 people showed up in the emergency room with whiplash. You know, you're in Philadelphia, my God. You know, Philadelphia is the. I always tell this story. People don't believe it, but this is absolutely true. That in the early '80s or late '70s, when CT scanning was just coming into Philadelphia, Temple had one of the first CT scanners. And somebody sent this woman up to Temple to have a CT scan, and the next thing you know, she sues Temple. And the suit was, before she had the CT scan, she had psychic powers. And after the CT scan, she had lost her psychic powers. So my question to her was, well, if you have psychic powers, why didn't you know not to get into the scanner? Right? However, she filed a lawsuit. It's so ridiculous you all laugh. In the early 1980s, this woman was awarded by a Philadelphia jury $1 million. So this is why it's important. This is why it's important to look for people with secondary gain. I always tell the residents, believe what a patient's telling you, but be skeptical about it. Many times they'll give you the best information in the history that will enable you to make the diagnosis. But particularly if there's secondary gain, I get a lot of people who come in with lawyers with them, you know. Then you have to worry that there's a problem. But these are some of the things that I think will allow you to pick up the most frequently encountered non-physiologic functions in neuro-ophthalmology. Thank you. We have time for some questions, Maria? Okay. Any questions? Go ahead, I'm listening. Ah, well, you see, now you're assuming that I tell them they're faking. Luckily for you, you don't have to do that, right? You just have to pass the information on to somebody. I see patients in neuro-ophthalmologic consultation, and the people who come in because of lawsuits or workman's compensation, stuff like that, they're usually sent in by other doctors. And I routinely dictate my note in front of the patient. So this, if I say something wrong in the history, the patient corrects me. It saves me I mean, I used to get hundreds of calls after a visit. You know, the worst thing in the world is seeing a man without his wife. He goes home and the wife said, "What did the doctor say?" I don't know. Well, do you have to? I don't know. I mean, I don't know. So if this wife is with him, I always bring the wife in the room during the examination because you get better information, you know, and then explain everything to the patient, but make sure the wife hears it. All right, but in the case of, and I send routinely after I dictate the note, I routinely send a copy of that to the patient. So the patient, and I did it because I wanted that if there was any corrections, the patient would send it to me. And Kathy Santa Maria said to me once, she said, "Well, that's a good reason too." And I said, "Well, what's the other reason?" She said, "Because patients don't believe that what you're telling them, you're telling their doctor." And I said, "What?" She said, "Oh, no, they think that what you tell their doctor is different than what you tell them." And I didn't believe that, but she was right, as she usually is. And the fact of the matter is now the patient gets a copy of the letter I sent to the doctor. So now there's no question about what I've said. Now, if I have someone that's a workman's compensation or a lawsuit, et cetera, and I want the doctor to know that there's nothing going on here, this is a non-physiologic problem, I say in my note, in summary, there are no objective findings to support the patient's subjective complaints. However they want. The more problematic one for me are the kids, who, a lot of kids have visual difficulties, you know, they get sibling rivalry at home, parents are divorcing, they've switched to a new school, and there's all this craziness going on. So I always tell the parents that I send the kid out, and I always tell the parents, you know, there's nothing wrong with your kid. I mean, I've tested him, and the findings show that his vision's perfectly fine. He's seeing 20/20, just, yeah. And the reason I think it's important, and I tell parents this, is that there is such a thing as psychosomatic problems. Something's happening with your kid, and I'm not a psychiatrist, I'm not going to analyze him, but I want you to understand that just because he came in today with some decreased vision, there's nothing to say that next week he won't have a bellyache. And he could wind up with an appendectomy that he didn't really need. So alert your pediatrician to this. And then I get the kid back in the room. And I say to the kid, I have examined you from the very front of your eye to the back of your brain, and there's nothing wrong with you. There is nothing wrong with your vision. But I've seen this happen before, and the thing that always happens is your vision gets better. In fact, I wouldn't be surprised if on the way home in the car, your vision started to improve. And just to make sure it improved, I'm going to see you back in 2 weeks. And once the kid knows that you've caught him and you saved him some face by saying, yeah, this happens to kids all the time, he'll give up the symptom, all right, even though you know. And if he doesn't give up the symptom, what have I wasted? Another visit, not a problem. The parents know what the real issue is, so then they can take the kid to whatever shrink they want or work out what's going on. So that becomes a very difficult issue and one that I don't think that you all need to address. But you need to let the doctor know that there's something here that's not kosher. Any other question? One more. We have time for one more. Yeah.
How often do you use the red-green glass test?
Red-green glass test for what? Visual acuity? No, you mean the patient can't see, they claim they can't see, so you put up the red-green thing, you know? Never. I have my own other tests that I use. I go behind the foropter, and when I was at Wills, we used to have foropters that had, went down to 2012, I think. So I put the kid behind there and I say, read that. And they say, I can't read that. I said, what? You can't read that? Come on, you can read that. No, I really can't. All right, come on. So I turn it up to 2015. I said, you see how much bigger that is? Read that. No, I'm sorry, I can't see any of that either. And the other thing about the foropters at Wills, at least in Neuro-Ophthalmology, is that they had 4 20/20 lines on them. All right? So I'd turn it up to 20/20, and I'd say, read that. Well, I can't read it. I mean, you can't read it. You see how much bigger it is. Oh, yeah, I see it's bigger. I can't read it. Okay, fine. I'll turn it to the next 20/20 line, and as I do that, I decrease the light in half. So instead of there being 5 or 6 letters there, there's 3 letters there. I said, now do you see how much bigger that is? Yeah. Can you read that? No, I can't. Well, look at the middle letter. Even if you can't read it, is it triangular? Is it circle? Is it square? Well, it looks like a circle. Now I know I got him. Because it's an O. And I say, okay, all right, that's good. All right, let me make it bigger now. So I'll make next 20/20 line, and I bring it down a little more. And by the time I get to the 4th 20/20 line, I get EVOTZ2. All right? So that's just the way I do it. But what I will explain to you is the best way to catch anybody is not to do something that's outside your normal routine. In other words, if I had to go looking for the red-green glasses and then switch the things in the foropter to put in the red, I mean, patients know I'm doing something out of the ordinary, all right? So I like to do things in the normal flow. And sometimes you just have to watch the patient. That's critical. You know, many of us, when we take a history or examine the patient's sitting here and we're like this if the desk is unranked. That's really bad. You should watch the patient. I remember when I was in the Navy, I had a guy who came in because he was hit by, I said, what's your problem? He said, I was hit by an airplane. I said, come on, you were hit by an airplane. He said, no, I was one of these guys on the aircraft carrier and the airplane hit me. And he had fractures of everything. And now he said he couldn't see. And he's in my office and he's got these dark glasses on, you know, and he's got all of these things on. And we're talking, and, you know, I was in the Navy. I didn't care if I saw a patient every 2 hours. It didn't matter. So we sort of had a nice sort of conversation about this and that, the Navy, the baseball, basketball. So I said, all right, I'm going to check the pressures in your eye. So I put the pressures in his eye, and as I always do, I sort of blotted his eyes, and I crumped up the tissue, and I said, here, pat your eyes. And he patted his eyes. I said, get rid of that. And he went right in the bucket. So watch the patient. I had a patient a month ago who came in with workman's compensation. He couldn't see somebody leading him in. And I said, okay, you can leave now, we're finished. And I walked out, and the resident said to me, where are you going? I said, come with me, watch. So I walked in the parking lot where I am now in San Diego, is across the street from the Institute, and you can see patients walking. So here he is, his friend is walking him across the street, leading him across the street. They get into the parking lot, he gets in the driver's side and drives away, right? That went in my report. Okay, thank you very much.